स्टार्ट कर लेना है. ओके. A very good evening, friends. Welcome to the discussion of AIIMS Ophthalmology June 2020. So let's begin with the first question. The question number 1 is, a patient is prescribed an eye ointment, an eye drop by a physician, and now this has to be instilled by the nurse. So what is the advice that nurse should be given, and how she should be giving this eye drop and the eye ointment? So again, I am happy that the things that we actually tell you in the class, things that we actually tell you in the class are always asked in the exam. And if you remember, I specifically told you that these are the practical things that you learn while attending your wards, going on. And what is that important thing is that whenever we treat actually the bacterial ulcers, especially the bacterial ulcers, the fungal ulcers, they are very, very virulent. So in that cases, we have to give both the eye drops as well as eye ointment. So you should know that which should be given first and which should be given next. So what should be the order? Now obviously, if you are giving the ointment, it is giving you a very, very thick consistency. So if you are applying the ointment in the beginning, I think the patient will not be opening the eyes for the next so many hours, and then you will not be able to instill the eye drop. So obviously, it's a good idea that you first give the eye drop and then you have to give the ointment. Now this is one thing, the order. First is the eye drop and then the ointment. Now one of the options they say that whether it should be simultaneous, whether the eye drop should be first or the ointment should be first, what should be the order. So I will say that first I have to give, the first thing is giving the eye drop, and then I have to give the eye ointment. And as you know that whenever we give the topical medications, we never give them simultaneously. Like if I am giving one thing, then I have to wait for some time and then I have to give the next. So that means I have to first give the eye drops. Option number 3 is the correct one. Eye drops first, then wait for 15 minutes and then apply the ointment. So it's a very practical thing of common sense. And if you remember that I told you that usually in the clinical practice, if I have a choice, we give the ointments in the night time, because in the beginning when there is a severe bacterial ulcer, we have to give these antibiotics 1 hourly. So we are giving the antibiotic 1 hourly, then we are giving the Midriatics and Cycloplegics, then we are giving some anti-allergic, then we are giving the artificial tear substitutes. So more or less every hour in the 12 hours of the day, every hour the patient is taking something. And if you ask him to take that same protocol in the night also, I don't think it will be possible. And that is why ointment is a good option during the night time. It is giving you full coverage throughout the night time. Plus, it is also giving you thick consistency. So when you apply it in the night time, usually you should apply it only when he has to do nothing else. He has done his basic duties, everything done, and just before going to the bed, we are giving this ointment. Now, one more important thing I would like to tell you, because this time they have asked you this. Next time they may be asking you something else also. If you remember, I always tell you that whenever we start the treatment of the corneal ulcers, we always start them on the empirical basis. Like we have this option, we can go for the culture, we can go for the sensitivity, and obviously that will give you great results, and you can give the antibiotic accordingly. But Most of the times it is not done, and we usually start the treatment on the empirical basis. Now let me tell you the reason also. The reason is pretty simple. If you see, especially in India, nobody is coming directly over the counters. Also they are taking antibiotic drugs, or by itself, or whatever they are getting at home antibiotic, they start instilling it. So basically by the time they appear to us, the ophthalmologists, they have actually started one or more antibiotics. I am telling you, one or more antibiotics. Now if I want to send the culture and sensitivity of this patient, that means I will have to first stop the antibiotics for 48 hours, at least 24 to 48 hours, and then I can send the sample. Then that sample will again take 24, 48 or 72 hours, and then that means I am stopping the drugs for a great amount of time. 48 hours here, 48 hours here. This is the minimum. This is the minimum I am telling you. So for 3-4 days I am stopping at a condition where the patient was already having a large ulcer. So that is not done. That is why most of the cases we are doing empirical treatment. We give broad spectrum antibiotics covering gram positive, gram negative, aerobic, anaerobic, everything, and we are also giving the fortified one. If you remember, I told you that we are also giving the fortified. How do you fortify? We take the injection ampules, take it out, and then in the eye drop with the help of a syringe, we are making the desired combination. In this way, we are making the fortified preparations. Like you must have heard these days everything is fortified, like in atta also they are fortifying with vitamins. Even I have heard that lipsticks are fortified with vitamin E. So these antibiotics are fortified to the desired concentration so that they can be treated adequately. Now one more important thing related to this. Can you see this? Yes, you have seen this multiple times. I told you this, that this is a simple fluorescein strip test. Simple fluorescein. This is a fluorescein strip test. I think this is the simplest test, and that is why I taught you in the beginning this test, beginning of all the tests, and everybody must have watched it, even if you have gone attended just one day of the ophthal OPD, because it's very common in the ophthal OPD. We are getting a lot of patients of the ulcers. So these fluorescein strips are basically, can you see this orange one? This is your fluorescein which is there, and what we are doing, we are instilling just a drop of antibiotic solution. Like we can use any eye drop, but it's good that we use the antibiotic so that it is preventing the contamination also, and just touch there, and then the patient will blink the eyes. So this, what it will do, it will actually stain the cornea. So whatever ulcer, that is the discontinuity that you are getting in the surface of the cornea, that will get stained. So name of this test, fluorescein strip test. The name of the stain, that is fluorescein. And another important thing, how will you see it? Through the cobalt blue filter. We are using the cobalt blue filter because you know these are the very basic things, and when we are attending our wards and duties doing there, we tend to come it naturally. And that is why in the classes also we always emphasize you that please attend your duties, because when I tell you these things in the class, obviously you will be able to correlate well when you have seen those things. So this is your cobalt blue filter. We will apply that cobalt blue filter over the slit lamp, and then you will see the green defect. So the color of the defect, the color of the ulcer, and that is why whenever you see any dendritic pattern, the ring abscess, single ulcer, or the multiple satellite lesions, every time what we see is the greenish color defect. Why greenish color? Because the fluorescein stain is staining it, and we are getting the green color. So these are the common things that is important. One more thing, everybody knows that we will give antibiotics, we will give the Medratics and cycloplegics, But you should also know that we also give the vitamin C. Vitamin C will help in wound healing. Vitamin C has a importance in wound healing because you know that most of the cornea is actually the collagen stroma. So that way vitamin C will help in the healing. So this was your first question. I think this is very clear. Okay, now we come to the next question. A 60-year man has undergone the LASIK for myopia. He has undergone the refractive surgery. Pardon me if there is any change in the language because these are the recalled questions and slightly variation can be there because it is based on the recall memory. So some people say 50 years, some said 55, 60. So that does not make much difference. 50 years, 55 or 60 years. Patient was there and he has already undergone the refractive surgery, the LASIK surgery for the myopia. Now they are asking what is the best method to check the IOL power. So I am happy that after quite a long time they have asked something related to the power and the cataracts, otherwise they were mainly focusing on other things. So I want to show you something here. First of all, if you see, we have got different generations for the calculation of power of IOLs. And can you see, we have got 4 generations here. That is, we have generation 1, 2, 3 and 4. Now there is a very easy way of remembering this. How will you do it? Now see this. Start with the first generation. So first is SRK1 formula. So 1 for 1. First generation is SRK1 formula. Then second generation is SRK2 formula. We will also be discussing what is actually SRK1, what is SRK2. So SRK1 is actually your first generation, SRK2 is your second generation. Then we have SRK3. Now 3 is starting with T like this. So it is SRK-T formula. This is standing for SRK-T formula. And then finally we have got, because everything is crossed, so we have holiday. So holiday, H for holiday and H for Haigis formula. So we have got different formulas here. Now I will tell you actually what is the concept behind it and why we require different formulas for the calculation of the power. Now let us start with the very basic, that is your SRK1 formula, right? Usually we are concerned with this formula only, that is we have got the SRK1 formula. Now SRK1 formula says that power is equal to A minus 2.5 L minus 0.9 K. I think you will agree with me that this is the most common and most important formula that we usually discuss, right? Now here P is the power, A is the IOL constant. A is the IOL constant, and if you see, these are 2 more constants that we are using. This constant is B and this constant is C. This constant is C. So basically we have got 3 constants here. We have got A, B and C. We have the values of B and C which are more or less fixed. So we have given the values, and the value of the constant A keeps on changing. So basically if you see the 2 variables which are here, L is the axial length. L is the axial length and K is your corneal curvature. Now this is the thing that most of us usually know. Okay, now there is a problem with this formula. The problem is that this says that basically the power P is dependent on this A constant. It is dependent on this A constant because if I take this axial length as well as this corneal curvature, if I take this axial length and corneal curvature same, means suppose I am talking about the same person 2 eyes. So same person 2 eyes, if they are having same axial length, same corneal curvature, then this means that both the eyes will require same power. But actually it is not. Actually it is not, because if we have 2 eyes, of same person. If we have got two eyes of the same person, then also power will be different, and power basically depends on, power will depend on two things. First of all, what is the effective position of the lens? The effective position of the lens. See, when I'm saying what is the effective position of the lens, basically I'm talking about the distance of the lens from the cornea, and it is also depending upon the geometry of the lens. So what I mean to say, that even if I'm talking about the two eyes of the same person having same axial length, same corneal curvature, it's not mandatory that both the eyes will be requiring the same one, because otherwise we are saying that basically this power is dependent upon A. So that will say that if I have the lesser IOL constant, then this person will require less power, and if it is more IOL constant, then this person will require more power. So actually it is not, and actually it is dependent upon the geometry as well as effective position. Okay, now this SRK1 formula, if I talk about this SRK1 formula, this is actually for the normal range of the axial length. Now you will say, what is normal range of axial length? It is between 22 to 24.5 mm. So this is between 22 to 24.5 mm of the axial length. So if I am not having this, so if I am having less than 22 mm axial length, or if I am having more than 24.5 mm of axial length, in these two cases I will require the second generation SRK2 formula. In those cases I will require the second generation formula SRK2 formula. Now what is this SRK2 formula? SRK2 formula will say that we have a addition factor. We have a addition or subtraction factor. That means if I have more or if I have less of the axial length, then I have to give one addition factor or a subtraction factor. Now let us see what is this. See, if you have more than 24.5 mm, so if it is more, so obviously I will have to give the subtraction factor, then I will give minus 0.5. So whatever power I am getting, formula will remain same. I will have to reduce, minus means I have to reduce 0.5 power from that. But if I am having lesser power, means if I am having less than 22, like it can be 22 to 21, then 21 to 20, or if I am having even less than 20. So in these conditions I will have to give the correction factor, that will be additive. So this will be plus 1, plus 2 and plus 3. So I think this is important thing, you must note it down. So if it is more than 24.5, I will have to give minus 0.5, and if it is lesser, that is from, now you may get this in your mind, that what if I am getting just 21, like because I am having 21 here also and 21 here also. So this is for the practical purpose, you can take it as 22 to 20.99, and then from 21 to I can take it as, right, 20, and then I am taking less than 20. So there should be no confusion regarding this. So now this is very clear that less than 22 and more than 24.5 I am taking the SRK2 formula. Now what if it is more than this? So if it is more than this, then in those conditions what we are doing, if it is more than 26 mm, if it is more than 26 mm, then again we are using a SRK formula. Then again we are using a SRK formula. This SRK formula is called as SRKT formula. This is called as SRKT formula. Now what is this T actually? I told you that T for 3, but actually here this T means theoretical. This is your theoretical formula. In the theoretical formula, what we are doing, because it is more than 26 mm. So I will have to personalize the constants. I will have to personalize the constants, and in those cases I will use this SRK T formula. SRK T formula. Okay, so this was about SRK1, SRK2 and SRK T formula. Now there is one more formula that you say is the Hoffer Q formula. This Hoffer K formula is basically for the pseudophakia. Pseudophakic AC depth is personalized. Now I will tell you what is the meaning of this. In the Hoffer K formula, what we are doing, see, normally the anterior chamber depth, we are taking for granted that whatever is the pre-operative anterior chamber depth, the same will remain afterwards also. So we are just not considering it. But if I have to consider this, and if I have to personalize this anterior chamber depth, what will be the anterior chamber depth after this IOL? After this IOL, then I use this Hoffer Q formula. So in the options, you were having SRK1 formula, you were having SRK2 formula. So obviously that is not the answer. Then you were having the Hoffer Q formula. Hoffer Q also is not for the refractive surgery, that is for the pseudophakia. So by exclusion also, you are left with the Haig's formula. So let's see this. Haig's formula is the answer here. This is actually the 4th generation. It is the 4th generation IOL power calculation formula, right? And obviously it is the latest, and I think this is common sense also, because if you are doing something for the post refractive surgery, that is 4th generation, that has to be 4th generation, has to be recent, because refractive surgeries are also latest. So what we are doing here I am using 3 constants. In the 4th generation ones, I am using 3 constants, that is A0, A1, A2. Now don't get scared, it is very, very simple. You actually already know the 3 constants, that is, you already know this one that we have taken here, this anterior chamber depth, so that is already taken, anterior chamber depth. Then there was a axial length, and one is your surgeon's factor. Surgeon's factor means the things that that depends upon the surgeon, what kind of surgery, the degree of astigmatism, all these things, what is the IOL that has to be used. So this is actually the most latest one that is used for the refractive surgeries that we are using. Now there is one more thing that I told you was the holiday. Now that is again very, very important, and it is said that till date that is considered to be the one of the best IOL calculation formula. That is considered to be the best IOL calculation formula. The reason is, can you see, it is using actually 7 parameters. It is using seven wonders of the word, 7 parameters it is using. Now let us see what are the parameters it is using. So some of the things are already that we are using, they are the same, like one is your anterior chamber depth, then we have the axial length and K reading. So these 3 things are common. Now see the height of personalization. It is seeing the preoperative treatment, the patient age, thickness of the lens, and wide to wide, means edge to edge also. So everything means it is totally dependent on the patient's personal parameters, and that is why this is considered to be the one of the most accurate calculation of the IOL formula. So based on these things, if you go back, what should I do? Hoffer Q is basically for the pseudophakia, right? And the SRK1 and SRK2 obviously is not for the refractive surgeries. So the answer is the Haig's, that is your 4th generation. And as I told you, this 4th generation formula is important because here you have got 3 factors. Again, let us revise it. We have A0, then we have A1, and we have A2. So these are the constants which are the surgeon's factor along with the axial length and along with the anterior chamber depth. So these three constants are important, and including these three constants, we have got other individual factors also that are considered in the Holiday formula. Okay, so now moving to the next one. Now this is again a question which is very much dependent on your practical knowledge. They are asking you about the operating microscopes. So operating microscope mein what is they are asking? They are asking about the numerical aperture of the objective lens. So if it is increased, what is the change in the image observed? Better magnification, better contrast, better resolution, or we have increased visual field. So let us see what will happen and what is actually numerical aperture. Numerical aperture means, suppose this is the objective of the lens, and this is your numerical aperture. So when the light is passing into the microscope and you are seeing it, so basically it forms a cone like structure, which is like an inverted cone like this. So light is coming like this, light is coming like this. So if you label them, this is your objective and this is your numerical aperture. This is the numerical aperture, and the light which is going is forming this inverted cone. This is forming the inverted cone, and if you see, this cone is formed, so half of the angle that is formed, this is called as angle theta. So if the aperture is more, obviously more light will come and you will have the better resolution. Basically, numerical aperture depends upon two things. It is the gathering of the light, how much amount of the light is entering inside it, number one, and second, what will be the resolution. So they have not given anything about the light, so your answer will be better resolution or increased resolution. Another important thing is that this numerical aperture is n sine theta. N sine theta. So you should know this. What is this n? N is actually the refractive index. Sometimes they also say that it is an index of refraction. So I think it's one and the same thing. Refraction is measured by this index. So it is an index of refraction, or it's a refractive index, and this angle theta is this one. So basically, what is the amount of light and what is the amount of resolution that you will be getting with a particular objective will depend upon its numerical aperture. So if you are having very small size object that you have to see, or it's very less fluorescent, you don't have much contrast, you will have to use the larger numerical aperture. Okay, now coming to the next question. A small pupil which remains same in the dark, a small pupil that remains same in the dark is seen in the condition of. So I think the first important thing here is that this pupil is small. The pupil is small. So if you look at the options, we have Arjun-Robertson pupil, the blind eye, the Horner's pupil, and Adie's pupil. So here, if you see this blind eye will means that there will be no stimulus. Now because there is no stimulus, this eye will be dilated and not small. This will be a big eye. So small pupil will not be found in cases of a blind eye. Then if you see the Adie's pupil, this is also a tonic pupil, and basically you are getting all the reflexes absent. That is why it is called as Adie's tonic pupil. So these two conditions are ruled out. You cannot have these because you are not getting a small pupil here. Now you are left with two things. So answer, I will explain you how. The answer here is actually the Horner syndrome, and let us see how. Now if you remember what we discussed in the classes, that Horner syndrome is actually a oculosympathetic paralysis. So let's discuss it again. Let's brush our knowledge about the Horner syndrome. What I used to say, that suppose this is your eyelid here, right, So this upper eyelid basically covers the upper 2 mm of the cornea. So upper eyelid covers the superior 2 mm of the cornea, and it is done with the help of this Mueller's muscle. So I'm not talking about the elevation. Elevation is done by the Alpheus muscle. I'm just saying that this upper eyelid will cover the superior 2 mm of the cornea with the help of the Mueller's muscle, while the inferior eyelid is just below the limber, so you are able to see the whitish portion, and this is done with the help of inferior tarsus muscle, right? Now we know that both of them have the sympathetic supply, and because both of them have the sympathetic supply, when we have the Horner syndrome, what will happen? We will have the oculosympathetic palsy. So in Horner syndrome, because we have oculosympathetic palsy, we will not be having this sympathetic supply. So Mueller's muscle will also not act, and this inferior tarsal will also not act. So what will happen? This upper eyelid will come down, right? Upper eyelid will come down. This is your ptosis. So what are the parts of the Horner syndrome that we discussed? We have ptosis, and this lower eyelid will also override upper in a upward manner. This will come here. So this is called as inverse ptosis. This is called as inverse ptosis. Now what happens in the pupil? Pupil becomes very small and meotic. We get a meotic pupil. Now this is important. Why we get a meotic pupil? Because there is also the palsy of, because we also have the palsy of dilator pupillae. We also have the dilator pupillae palsy, because you know dilator pupillae is having the sympathetic supply, and that is why we have actually meiosis. Then along with this we have anhidrosis, and we also have loss of ciliospinal reflexes. Now let us discuss a flow chart that will help you in reaching this, that we have understood that it is due to the dilatation it is due to the absence of the dilatation, because we have the dilator pupillae muscle paralysis, and that is why we are getting this. So let us discuss that. Now see here, whenever you have the anisocoria, try to understand, whenever we have anisocoria, now first of all I will tell you what is anisocoria. When the difference in the pupil size is more than 0.4 mm between the two eyes. If you are having the difference in the pupil size between both the eyes, which is more than 0.4, then I will say that this is anisocoria, because physiologically you can get up to 0.3 mm difference between both the eyes. Now suppose I want to check whether this anisocoria is due to the third nerve palsy or Horner's palsy or the AR pupil, because many of the students have, I think, corrected, put a tick mark on the AR pupil also. So let us try to solve it. So what you have to see, that whether it is increasing in the dark or whether it is increasing in the light conditions. Whether it is increasing in the dark conditions or it is increasing in the light conditions. Like in our question, it is increasing in the dark condition, it is remaining small. Now what happens if this condition is increasing in the light? So this means that your abnormal pupil does not constrict due to the light. if this anisocoria is increasing under the light conditions, that means normal pupil is showing the light reflex when the light is shown to it, but the abnormal pupil is not showing. That is why there is increase in the anisocoria. So now what happens? The abnormal pupil is not constricting. So constrictor fibers, here is your sphincter pupillae. That means the impulse is not reaching to the sphincter pupillae muscle, and here we have a problem with the parasympathetic supply. So we have a problem with the parasympathetic supply and not the sympathetic supply. Okay, now what you are going to do, we will give the pilocarpine. Next important test is that we have to give the pilocarpine. Give pilocarpine 0.125%. So when you give this pilocarpine, you have to see whether it is constricting or not. Now there are two options: constriction, if it is constricting, or if there is no constriction, right? So you have to check it. If there is constriction, that means this is your Ades tonic pupil, right? Now in our case, we are having the reflex that was increasing in dark, so we do not go with this Ades tonic pupil. Now suppose it is not showing any constriction, then we will give more concentration. So now give pilocarpine, try with a larger concentration, give pilocarpine 1%. Give pilocarpine 1%. Now again see the constriction. If it is present, then it is the third nerve palsy, and if it is not present, then it is your AR pupil. So if you see here, your option of AR pupil is again under the lighted conditions. Bilateral constricted pupil, irregular pupil, you get in cases of AR pupil, and that will show the anisocoria that will increase under the lighted conditions and not the dark conditions. You also have this Ades tonic pupil that will show the constriction with 0.1 to 5%, again anisocoria increasing in the lighted condition. Now come to this dark. So only anisocoria that actually increases in the dark is actually the Horner syndrome. Now I will tell you why this is occurring. Actually what happens, whenever we have got the dilatation of the pupil, whenever we have the dilatation of the pupil, it is due to two reasons. First, there will be relaxation of the sphincter, right? It is the relaxation of the sphincter. And number two, it is the contraction of which muscle? Because we need dilatation, so it is the contraction of the dilator pupillae. Contraction of dilator pupillae. Now in Horner syndrome, we are having oculosympathetic palsy. So I will not get this contraction of dilator pupillae. So I am getting this dilatation only due to the relaxation of the sphincter, and therefore what I am going to get is the dilatation leg. So this is a very important term that you can say with respect to the Horner syndrome. There is always a dilatation leg. It will dilate due to the relaxation of the sphincter, but certainly it will not do it at the same time. So even we can check it under the dark conditions in our OPD rooms also. Switch off the light and show the torch light from below, okay, and then remove. So you will see that there is a dilatation leg in the other eye by about 4 to 5 seconds. So that particular dilatation leg, which is actually increasing in the dark conditions, is found in the Horner syndrome. So you should be very clear. It should be very clear that it is not the AR pupil and it is just your Horner's pupil. I suppose this is very clear to you, right? Yeah. I think you must be remembering that I was banging on you before the AIMS exam, and we had a YouTube session also. I had posted a video also. We discussed so many times in the class also, and a very similar question we had discussed in our live class also on the PARC test. So see, this is the reason why we have a high strike rate, because we are in a position to guesstimate that what is actually going on in the examiner's mind and what will come. See, so I am happy that we can help you by knowing these things. So let's do one more time. Yeah. So patient having left-sided head tilt. In examination, there is a right-sided hypotropia. It is increasing on the dextroversion and with the right head tilt. So it is increasing on the dextroversion and the right head tilt. And I told you, don't go with that triangle formula, because you will not be having that pen and paper in the exam to do all this. So we will do it more of a theoretical one in our mind. Okay, so what can be the condition? If it is a right-sided hypotropia. So what I told you, either it is actually the right eye hypotropia or it can be the left eye hypertropia. That is why we are having the relative hypo. Yeah. So either it is a right eye hypotropia or left eye hypertropia, because even if we have the right eye hypertropia, if you remember, I told you that we usually analyze and do the working on the patient with respect to hypertropia. So if I am getting right eye hypotropia, I will say that this is a left eye hypertropia. So let us see what are the muscles that can be involved. So if I say that there is a right eye hypotropia, that means elevators have paralyzed. So right eye superior rectus can be paralyzed, or the right eye inferior oblique can be paralyzed. If I am saying left eye hyper, so that means depressors of the left eye have undergone paralysis. So I can have the left eye inferior rectus, or I can have left superior oblique. So I think this is the first step. This is very, very clear. First you have to see which eye hypertropia, which eye hypotropia, number one. Now what was the second step? You have to see it is increasing in which gaze. So let us try to make the eyes, right? This is how I told you. Make the eyes, and they are saying that it is increasing in the dextroversion. So patient is seeing like this. Okay, now see which eye is going in abduction and which eye is going in adduction. See this, right eye seeing rightward, so obviously same side eye will go out. So this will be going in abduction, and the left eye is going towards in, so this is going into adduction. Now what you know, maximum elevation and depression in the abducted eye is by rectus. So abducted eye is by rectus. Maximum elevation and depression in the adducted eye is by oblique. See, I have got two options now. Out of the four, I have got two options. Answer is either superior rectus or it is superior oblique. Now it depends on the third point. They are saying it is increasing in the right head tilt. And to confuse you, if you remember, I told you specifically that you don't have to see which side head tilt it is. You have to see in which head tilt it is increasing. So even if they do not write it that it is increasing in the right head tilt, it is obvious because the patient is showing left head tilt. So patient will not tilt in the his head in the direction in which it is increasing. Like this is the nature's rule. The patient is compensating. This is called as compensatory head tilt. So patient is showing compensatory head tilt to compensate what? Diplopia. So obviously he will not tilt his head in which it is increasing. He will tilt his head in which it is decreasing. So if he is doing compensatory head tilt towards the left side, that means it will increase in the right head tilt. So what will happen? Right head tilt means like this. So this is right head tilt. Right now what will happen? There is a counter rolling mechanism. So if I am doing the right head tilt, this eye will go inward. So what I am going to write, there will be intorsion in this right eye, and this eye is going out, because of the counter rolling mechanism. So this will be extortion. Now apply the simple funda sin, that is superiors are in tortoise. So I require a superior muscle here and I require inferior muscle here. Now see here, right eye superior rectus, yes, this can be there. While if you see left eye superior, so I require the inferior muscle, this is not. And you have got the answer, right superior rectus. Don't see anything else, just follow 3 steps, see in which eye we have hypertropia, in which gaze it is increasing and in which head tilt it is going on. You are there with the answer. Okay. Yeah. Now another question. If you remember, last time also they had asked a drug, that is topiramate, that was causing the glaucoma. So nowadays they are asking more and more questions on the side effects which are causing the ocular complications. Somehow these AIIMS people, I think because of the RP center, they are more and more concerned about the ophthalmic and ocular complications of the drugs. So let us see what they have asked this time. Anticonvulsant drug which causes bilateral constriction of the visual field. Bilateral constriction of the visual field. So answer is pretty simple here. This is actually the vigabatrin. Vigabatrin is anticonvulsant drug. This is usually given in those people means in those children who are having the tuberous sclerosis, we have mental retardation, we have got seizures, and these babies are given vigabatrin. Now you must have read all these things in the pharma, but let us see this vigabatrin. Now see, it contains GABA. Can you see the word GABA is there? So this is actually a selective, this is a selective and irreversible. Selective irreversible GABA transaminase inhibitor. So this information is given in the name itself, it is vigabatrin. So I think this is a good way of remembering the things, because most of the times exams there's a problem in recalling. So see, this word GABA is already given here. R for reversible, we are having I also, so this makes it irreversible. So we have got the selective, we have the irreversible GABA transaminase inhibitors, and this is actually responsible for the bilateral constriction of the visual field, and this is occurring due to the toxicity. This is due to the toxicity of the rods and cones, that is your photoreceptors. Basically, it is causing the toxicity of the photoreceptors. Mostly it is asymptomatic, but babies have slowly and gradually more and more constriction of the visual field, and obviously we will have to check them. So how can we check this? We can do the fundus examination regularly, we can call the baby, or OCT is a very good non-invasive technique, we can do it, but main problem is how to get the cooperation of these babies. And then we can do the VEP, visual evoked potential, we can also do the ERG, but most of the times the parents, they are not very happy with this, and they usually are in favor of fundus examination, because obviously for the other things you will have to give the GA. So I think this is the first thing that we go for. We can go for the fundus examination. Okay, now because they are asking these things again and again, so I thought why not prepare a chart and a table for you people for the quick revision afterwards also, because now it has become a habit of the AIIMS people. They are asking the systemic drugs with the ocular complication, and see on the top I have taken the topiramate that was given in the previous paper. That was your true and false type of question. Topiramate causes a secondary angle closure kind of glaucoma, right? Then very important thing that you already know, chloroquine, hydroxychloroquine, it causes the bullseye maculopathy or the bullseye retinopathy, annular benign concentric macular dystrophy it is also called as. And that is why, if you remember, I told you that this drug we are not giving to the COVID patients, corona patients if they are already retinotoxic. So if the patient is retinotoxic or having the retinopathy, so we will not give the chloroquine or hydroxychloroquine group of drugs to these people. Then comes the tamoxifen. So remember that tamoxifen is responsible for a crystalline kind of maculopathy, and very soon we will be having a off the rewind series related to these ocular complications of the drugs, and there I'll be discussing everything in great detail also. Then see this, the drug that has been asked this time, vigabatrin, permanent bilateral concentric visual field constriction. Then sildenafil, because so many people are taking for the infertility, so this is actually causing the non-arthritic kind of ischemic optic neuropathy. Okay. Then we have ethambutol, we have chloramphenicol. This is causing toxic optic neuropathy. Apart from this, you already know methyl alcohol, ethyl alcohol, we have tobacco, we have got digoxin, and then we have got the amidron. All these drugs are also causing the optic neuritis. You already know ocular steroids. What is the formula that we remember? GTCS, yes, topical steroids causes more of glaucoma, and systemic steroids more of cataract. So this you already know. Then if you remember, we also discuss the vortex keratopathy. Vortex keratopathy, this is also caused by so many of the drugs. Vortex keratopathy, what was the formula? It was Fabry's pica. It is the Fabry's pica. Now what is this formula? Fabry's pica means, here I have the Fabry's disease, right? And here I have a pica. Pica, this is your phenothiazines. Then we have indomethacin. Then we have chloroquine, and chloroquine you are getting everywhere. And then we have amidron. Vortex keratopathy, which is also called as the cornea verticillata. So all these drugs are important, and we'll be accumulating more and more drugs. Already there are so many drugs which are causing the cataract also, the toxic optic neuropathy. Then we have got the color blindness. Then we have got the color related things, like if you remember, I told you that digoxin is responsible for the yellow colored vision. And if you remember, when I discussed the next pattern question between the medicine and ophthalmology, and you people prompted the answer just by this yellow vision, that answer is digoxin. So even this happens sometimes, right? Then even your ethambutol also causes the red and green color blindness. Green color blindness is also caused by it. Then if you see this chloroquine, it is also causing the red and green defect. Ethambutol is causing the total blindness, while chloroquine is causing the defect. And if you see this one, the sildenafil, this causes blue green defect. So there are a lot of color defects as well as blindness, which is also occurring with the help of drugs. So it is a good idea that we can accumulate everything at one place. Like we have read all the things in different chapters. You have read about bullseye retinopathy, toxic cataract, toxic optic neuropathy. You have read about the vortex keratopathy. Now make one chart at the end of your register and write all the drugs and their ocular complications there. So I think that will be a good way of remembering the things. Okay. Another important question that we frequently discuss in our classes: what is false about the corneal epithelium? Bowman's membrane can regenerate. Limbus has stem cells. This is true, right? It is lined by stratified epithelium. This is also true. And apical cells have microvilli. This is also true. So the answer is the Bowman's membrane can regenerate. Now if you see here, this we have discussed so many times in the classes, that how will you name the layers of the cornea? I always say that it is A, B, C, pre-D, D and E. A is your epithelium. So it is non-keratinized stratified squamous epithelium, and epithelium is not very thick. It is just 10% of the corneal thickness, and it is also responsible for maintaining the fluid level. Like we all know that endothelium is the main layer which is responsible for maintaining the fluid levels, but along with the endothelium, epithelium also plays a role in maintaining, but we do not come to know, yes, because of the tight junctions. So we have got the tight junctions in the epithelium. If you see here, most of the times if you see, this is the epithelium. So we have got the junctional complexes or the tight junctions. That is why this fluid actually is not able to go to the stroma, right? So epithelium can regenerate and it is able to maintain the fluid levels, and it is not sending it to the stroma because of the junctional complexes. Now B, we will write it with blue color. So B is for the Bowman's membrane. B for Bowman's membrane, right? This is actually acting as a B for barrier. So this is acting as a barrier and it is not letting the fluid pass from the epithelium to the stroma, and it cannot regenerate. So I think this we have discussed so many times in the classes that it is Bowman, it is bowing his head because it cannot regenerate. So a thing which is not regenerating, so how will it heal? It is healing by the fibrous tissue. So it is making the fibrous tissue, that means you will have the scarring. So basically whenever you have scarring in the cornea, we are having the opacification, it is due to the defect in the Bowman's membrane, right? Then we have C is for your connective tissue stroma. So obviously connective tissue stroma is making the bulk of the cornea. C for cornea and C for connective tissue stroma. So it is making bulk of the stroma, right? Then C for collagen. It is made by the collagen. More than 90% of the thickness is actually made by this stroma. Then we have predescent, descent and endothelium. Predescent's membrane, you know, predescent's membrane is the newly discovered membrane, also called as the Dawes layer, and very thin, 16 micron thin. We do not know the exact function, but now the toughest. So next time they can also ask you this, because this time they have asked you a question, and if you remember, I told you that every time they ask you question either in corneal ulcer or the layers of cornea. So this layer, previously the Descemet's membrane was the toughest layer. Now the toughest layer is this predescement's, and then we have Descemet's. And I think Descemet's membrane does not require introduction. Descemet's membrane is the most resistant one to mechanical trauma, to chemical trauma, to bacteria, and previously it was the toughest one also. We have Descemetocele herniation, preventing the impending perforation. We have got Descemet stripping, complications of cataract surgery, detachment of the Descemet's membrane. We have Schwalbe's line, the prominent end of the Descemet's membrane. And then we have endothelium. It is like powerhouse, metabolically active layer is there. And can you see, we have got a single layer of cells. Here we have got just the single layer of the cells, hexagonal cells they are. And this is one area where we have the sodium potassium pump, and this is also responsible for maintaining the fluid level. Now what happens whenever we have glaucoma, we have raised intraocular pressure, these junctional complexes which are present in the epithelium, which are present in the endothelium, they are not functioning, they become permeable, and that is why a lot of fluid gets accumulated within the stroma, and that is why we get the edema and haziness. So that is the reason actually. And you should know we have got hexagonal cells seen by the specular microscopy. Now there is one more thing. What they are saying is that we also have this microvilli. So we have got the villus structure. Villus structure is present on the apical cells. So apical cells we have got in the epithelium also, and the apical cells we have on the endothelium also. And what they are doing, see, whenever we have villi, what happens? It is increasing the surface area and it is going outside to the aqueous humor. So these villi are actually coming from the cornea and they are going into the aqueous humor. Exact reason is not known, but many people say that it is going into the aqueous humor to take the nutrition, because you know cornea being avascular requires the nutrition from the aqueous humor. Now another thing, what they are saying, if you see the question back, we have got the stem cells. So that also you know that we have got the proliferating cells which are present at the limbus, and which is helping in the healing also. So they are actively mitotic cells, or they are dividing cells, proliferating cells, also called as stem cells, which are actually making the palisades of Vogt. They are making the palisades of Vogt. They are present at the limbus. So answer is pretty clear. Bowman's membrane can regenerate. That is wrong. It cannot regenerate. Okay. Now finally we come to the RBSK. RBSK is actually your a kind of rural health, public health, right? So what is this actually? This is your Rashtriya it is actually the Rashtriya Bal Shiksha and this is actually including the 4 Ds. It is actually including the Rashtriya Bhavishya Swasthya, Rashtriya Bal Swasthya Kalyan. So this is actually including the 4 Ds. So 4 Ds which are included here, that is consisting of so many things. So I will tell you how to remember these things. We have got the defects also, we have got deficiencies also, we have got diseases also, and the developmental delay. These 4 Ds are there, and basically they are aspiring for early intervention of the child from 0 to 18 years. So if the child has any kind of disease, so we can have the early intervention of that child. So all the important diseases of the children are included here, and we have got 4 Ds. If you see here, D for defects at birth. One is the D for defects at birth. We also have the deficiencies. Then we have diseases of the childhood, and then we have the developmental delay. Now how to remember this? What are the defects at birth? Now see, the defects at birth, D for D. So we have got the Down syndrome. Then all the important things that you find in different of the subjects, like we have got the clubfoot, then we have the neural tube defects here, then we have got the cleft lip and palate. Now if you talk particularly of the eye, so because they have talked about the eye particularly, see, they have given you congenital cataract also and ROP. So congenital cataract is also there, we have congenital deafness is also there, we have ROP also, and congenital heart diseases. So 2 of the options are here covered. Now if I am talking about the deficiency of all the nutrients, so it can be vitamin A also, vitamin D also, all over malnutrition can be there, deficiency of the thyroid, it can cause the goiter. So vitamin A is also there. So here comes the answer, that it is the glaucoma which is not included. So it is the glaucoma which is not included. So like every time they used to ask what are the things which are not included in Vision 2020 program, and in 2020 they have not asked about the Vision 2020 program, and here they are asked about the Swasthya Karyakram. So no matter. So you have to remember these things, all the diseases of the childhood, all the defects, the deficiency, as well as the developmental delays are included. So I think with this we have come up to the end of this live session. I hope you enjoyed the session and you have gained so many things also. We have a kind of a brushing up of the important things, and also I want to wish you all the very best for your coming exam. Go freely and be very very motivated and positive, because just before the exam we always, like, this is a common feeling, we all feel that we do not remember anything, everything has gone out of our minds, how to recall. But remember that everything is actually there, it becomes dormant, it is hidden in your neurons, and when the thing will come in front of you, the question will come in front of you, and you will be reading the options, it will come automatically. So that will come out of you as in when required, so attempt the question paper very very seriously, focusing on the options, because you know PGI paper is a test of patience. Every option can be correct there. You have got so many questions, 250 questions, so many choices, 5 choices, so together you have a large bundle of choices, 1250 choices, and each choice can be an answer. So there you are not satisfied after getting one answer. So I think that is there, but side by side it is also a very conceptual paper. They do not give very hi-fi things, they just check your concepts, plus also see the previous year's papers, because there are certain topics which are always repeated in the PGI, so those things are always there. And maintain the calm while reading the choices, and don't be very conservative in marking, and don't be very exorbitant. Take it 50